So ADHD is attention deficit hyperactivity disorder, and it's characterized by the presence of three core symptoms. 1, hyperactivity, 2, inattention, and 3, impulsivity that is developmentally inappropriate. If I just go through some of the core symptoms, so going back to hyperactivity, so the patient is constantly moving. They are generally running about or climbing excessively in situations when it's not appropriate. They can talk excessively, fidget or squirm in their seat, and in classrooms they tend to leave their seats, or in other situations they can just get up and leave. Around impulsivity, they may have difficulty waiting their turn. They can interrupt conversation. They can blurt out answers before questions have even been completed, and they tend to do or say things without regard for the consequences. With regards to inattention, they're easily distracted, they have a short attention span, they don't seem to listen when spoken to directly, and they don't follow through on instructions, and they fail to give close attention to detail, and make careless mistakes. Now, the prevalence rates for ADHD vary between countries and depending on what you read, really, but the rate is usually put between 3 to 9% in the UK, and that roughly translates to between 1 and 3 children in an average classroom. Around 2/3 of adolescents will continue to meet the diagnosis into adulthood. Now, in terms of gender, ADHD is diagnosed at a ratio of roughly 4 boys to 1 girl, and it does fit into the category of a neurodevelopmental disorder. Now, ADHD is seldom a pure diagnosis. In most cases, it's accompanied by other comorbidities. Now, the overlap represents similarities between ADHD symptoms and the comorbid symptoms, and they can really add to the complexity of diagnosis and ongoing management. So there's no exclusive risk factor that contributes to ADHD, but instead the risk of getting it is likely to be due to complex interactions between biological, physical risk and family and or environmental factors. The pathophysiology is unclear, but there is growing evidence that it is a neurobiological problem, and it's thought to be the deficiency of both dopamine and noradrenaline that leads to the classical difficulty patients with ADHD display. So, considering that complex picture, diagnosing ADHD is challenging, particularly as there's no formal blood test or scan. So arriving at a diagnosis typically takes up to a year, but can take longer in more complex cases. The reason for this is because a comprehensive assessment needs to take place. The Diagnostic and Statistical Manual of Mental Disorders criteria and the International Classification of Disease can be used in the diagnosis of ADHD. Now, once a diagnosis has been made, it can be classified into one of the following. So it could be classified as a combined presentation if enough symptoms of both inattention and hyperactivity and impulsivity are present for the past 6 months. It could be classified as a predominantly inattentive presentation, so if enough symptoms of inattention but not necessarily of the hyperactivity and impulsivity are present for the past 6 months. Or predominantly hyperactive impulsive presentation, where, as it sounds, enough symptoms of hyperactivity and impulsivity but not inattention are present for the past 6 months. Now, once ADHD is diagnosed, the level of severity will be ascertained from the degree of impairment it causes. Now, the condition can be classed as mild, moderate or severe. Now, although ADHD-like symptoms have been described for many years and the diagnosis has been recognised for over 3 decades, controversies around it still remain. To this day, many view ADHD as a label for naughty children or a failure in parenting. Media reports, particularly around increased prescribing of stimulants or their use in enhancing performance, further add to this controversy. It's therefore not surprising that parents are often wary of accepting this diagnosis, or there is disagreement between parents. So the management of ADHD requires a holistic approach with involvement from a number of areas, so medical, school, social and family. So it's useful to pause for a moment and think about how a patient may be feeling throughout this. The child would have been struggling in their domain, so schoolwork, friendships, relationships and emotionally for many months, if not years. Typically the child would have gone through months or years of being told off, more than his peers. Children with ADHD may develop some sense that they are different, not as good as their peers, and view themselves as naughty. They will note that they do not tend to get invited to things like birthday parties, a friend's house or sleepovers. Add to their experience regular clinic reviews where they'll have to listen to their parents and school reports describing negative behaviours and difficulties. It's unsurprising that this whole experience can lead to the patient feeling low, lacking in self-esteem, disengaged, resentful, or even angry. It's therefore vital that the clinician engages with the patient at an age appropriate level and tries to understand their views at every opportunity. It can be useful to ask the patient to reflect on their difficulties before and after treatment. This gives the patient, as well as the clinician, an understanding of the efficacy of the treatment approach and secures future engagement. From the parent's point of view, there may be feelings of confusion or even guilt mediated by the associated stigma and preconceived views. It's therefore important that clinicians explore parents' thoughts and feelings about the diagnosis and medicating their child. This allows misconceptions to be clarified and the parents to feel comfortable with the treatment plan. Now, individual goals need to be set with the parents and the patients where it's possible. This, along with psychoeducation, ensures that parents and patients have realistic expectations. The generic goals of treatment are to use a combination of drug and non-drug measures to ensure that the patient can thrive in all domains and enjoy a fulfilling childhood. So if we look at some of the things that could be managed. So firstly, behaviour management. Now, NICE guidance recommends that a parent training education program is useful, particularly in conjunction with medication. Younger children will not have reached the level of development required to regulate their own behaviour, so clinicians need to work with parents and others around them. As a child gets older, moves into adolescence, more work can be done directly with the patient to influence behaviour and emotions. Now, behavioural interventions in ADHD have been used for over 2 decades. Evidence shows that behavioural parent training and behavioural modification in the classroom are regarded as well-established treatments. These interventions can also help manage other behaviours associated with comorbidities such as conduct disorder. Typically, these behavioural programs help enhance core parenting skills such as parent-child relationships, so for example spending time and showing affection. They can encourage desirable behaviours like use of praise and rewards. They can teach new skills and behaviours, for example setting a good example, and you can also manage undesirable behaviour by setting ground rules, ignoring certain behaviour, by dealing out punishments or timeouts. Now, sleep could also be managed if that's an issue. So the amount of sleep needed reduces as a child gets older. In addition to tiredness, chronic lack of sleep can lead to lack of concentration, mood swings, and irritability. Some of these symptoms may be misconstrued as ADHD or deterioration of ADHD. So it's therefore vital that a patient with ADHD and their parents are supported to optimise sleep. So typically a patient with ADHD struggles with sleep initiation, so that's getting to sleep, but they're often fine to sleep once they've actually got to sleep. The reason of this could be that their hyperactivity makes them unsettled. They will therefore struggle to sit or lay long enough to actually get to sleep. There are a number of strategies that can help optimise sleeping. So encouraging activities outside, exposure to fresh air, that can make the patient expend excess energy and get tired. You could use relaxation techniques like focusing on breathing, music, dim lighting. Bedtime routine is very important because it's the subtle cues that actually settle the brain to get ready for sleep. Sitting with a child before they go to bed so they can get to discuss their day, get rid of any anxieties or likelihood of nightmares. Making sure the bedroom is comfortable, quiet and sufficiently dark. Don't have a TV in the room and avoid all electronic devices an hour before bedtime to reduce that stimulant effect. And keep the weekday and weekend routine similar so they don't have this fluctuation in routine. Now at school, if we think about how long patients spend in school, it is a considerable amount of time. It's an environment where they not only acquire academic skills but also social skills. So these patients with ADHD will inevitably find the classroom environment difficult due to the expectation to sit still, not make a noise, wait their turn and concentrate for a period of time. Equally, playtime or free time can be challenging as it's unstructured with fewer boundaries. So schools will utilise a variety of resources to ensure that the patient has the best access to the curriculum. Strategies will include work that is differentiated to the patient's level, help from a teaching assistant in a mainstream classroom, small group work, one-to-one interventions, and a condensed timetable. Patients may even get help from speech and language therapy, occupational therapy, school nurse and local teams that help them to better manage their emotions. Extra provision for exams can be provided, such as using computer, scriber and reader, and allowing extra time. And when the patient transitions from primary to secondary school, that can also be a turbulent time for the child and also for the parent. Primary schools tend to be smaller. Children are often taught in 1 to 2 classrooms and by a few teachers, where they can actually build a relationship. In contrast, secondary schools are bigger. There's a frequent need to move between lessons. They have to become more accustomed to many teachers and be more organised. So this can be problematic for patients with ADHD also.